We would look at megaloblastic anemias. Megaloblastic anemias. Now, in the previous lecture, we talked about iron deficiency anemia as a kind of nutritional deficiency anemia. So we talked about iron, but today we would be looking at megaloblastic anemias. And under megaloblastic anemias, there are two main types of anemia, which is vitamin B12 deficiency anemia and folic acid deficiency anemia. And then we'll mention a little bit of what we call pernicious anemia. But pernicious anemia, you would find that it is not really because of a lack of nutrients, but as a result of some autoimmune, disorders. So what is megaloblastic anemia? From the name megaloblastic, so it means that the cells in this type of anemia would be megaloblast. They will be very big. They'll be macrocytic. So the first thing you need to know about megaloblastic anemia is that there will be macrocytic cells. The cells will be macrocytic. They will be big in size. Unlike for iron deficiency anemia, where we said that it will be microcytic, the cell will be small. But for this one, megaloblastic anemia, the cells would be big. So they are megaloblasts or macrocytic cells. So what happens and what causes megaloblastic anemia, and what exactly is megaloblastic anemia? Now, introduction. So megaloblastic anemia is characterized by defective synthesis of DNA in all proliferating cells. So one of the things that happens in megaloblastic anemia is that there is defective synthesis of DNA. Now, when cells are proliferating, they divide, okay, and there is synthesis of DNA. Now, without DNA synthesis, you cannot form normal cells. So what happens in megaloblastic anemia is that there is a problem or a defect in the synthesis of DNA, which is as a result of a lack of folic acid or vitamin B12. So that means that folic acid and vitamin B12 help in DNA synthesis. So a lack of any of them would mean that there will be defective synthesis of DNA. So in the process of erythropoiesis, the red blood cells will have a defective DNA synthesis. Okay, so that is what happens. And this defective DNA synthesis is due to lack of folic acid and lack of vitamin B12. So you can say it is due to lack of vitamin B9 and lack of vitamin B12. Okay, let's see. So let's start with vitamin B12 deficiency, because we have said that megaloblastic anemia could be as a result of B12 deficiency or folic acid deficiency. But we're going to start with the vitamin B12 deficiency, how it causes megaloblastic anemia. Now, both of them, both vitamin B12 and vitamin B9 or folic acid, have the same picture in terms of the size of the red blood cell that will be formed. Both of them would produce megaloblastic cells or macrocytic cells. But in terms of the clinical manifestation, there are a few differences which we would see as we proceed. So let's go ahead. Now, in this slide, we're talking about the normal chemistry, okay, of vitamin B12, the biochemistry of vitamin B12, the structure, the chemical structure of vitamin B12. For me, this is not very important for the anemia, okay, but just know that vitamin B12 is composed of a corine nucleus, which has 4 chiral rings. that are bound to a central cobalt atom. And then there are different atoms or ligand to which the Corine nucleus is bound. And according to the type of atom, we have different types of vitamin B12. So we have what we call cyanocobalamin, or we have hydroxycobalamin, we have adenosylcobalamin, and methylcobalamin. But all of them are just different types of vitamin B12 based on what ligand the cobalt atom is bound to. Okay, so how do we get vitamin B12? What are the sources of vitamin B12? So vitamin B12 is gotten from liver, dairy products, and sea fish. So these are the major sources of vitamin B12. And it is gotten from animal products, okay, from animal products. So people who are vegetarians who don't eat animals at all, they don't want to eat anything that is animal, they want to only eat fruit and plants and vegetables, are at a higher risk of getting vitamin B12 deficiency anemia because they are not taking animal products. But you get vitamin B12 from animal products, so from liver, dairy products, and sea fish. Now, although bacteria in the large intestine synthesizes vitamin B12, it cannot be absorbed from this site. So vitamin B12 cannot be absorbed from this site. The vitamin B12 that the intestinal bacteria synthesize cannot be absorbed from the intestine. And so we need to take in vitamin B12 in our diet. Okay, and the minimum amount required for an adult is 1 to 4 micrograms of vitamin B12 daily. So every day we need 1 to 4 micrograms of vitamin B12, and you see this majorly in animal products. Okay, now how is vitamin B12 absorbed? So there are two mechanisms for the absorption of vitamin B12. Now you have taken vitamin B12 in your food, but how is this vitamin B12 absorbed? Now we have two mechanisms involved in vitamin B12 absorption. We have the active process and the passive process. So in the active absorption, it makes up 75% of the mechanism of absorption. So it requires the presence of what we call an intrinsic factor. So for active absorption of vitamin B12, we need a factor that is called intrinsic factor. It is the glycoprotein that is produced by the parietal cells of the stomach, okay? So glycoprotein called intrinsic factor is produced by the parietal cells of the gastric mucosa of the stomach. That means that if there is a problem with the parietal cells of the stomach, there would be no intrinsic factor. And without intrinsic factor, vitamin B12 cannot be properly absorbed. So 75% of vitamin B absorption is done actively with the help of intrinsic factor. Now, another name for intrinsic factor is called Castle factor or Castle factor. Castle factor, because sometimes in exams, they might not put intrinsic factor there. They would put Castle factor. Which of the following is needed for vitamin B12 absorption? A, Castle factor, and they'll put other things there without including intrinsic factor. So if you don't know that the name is also called Castle factor, you probably would fail that question. So intrinsic factor is also called Castle factor, and it is produced by the parietal cells of the gastric mucosa. Then the passive or 25% of vitamin B is absorbed through diffusion. And this process happens when you take a drug, a vitamin B12 drug. So you could go to the pharmacy and get vitamin B12 as a drug. Now that one is absorbed through diffusion. It doesn't require intrinsic factor for its absorption. Okay, but normal vitamin B12 that you get through diet needs to be absorbed through the intestine with the help of the intrinsic factor that is produced in the stomach. Okay, so here we have a scheme that is showing us what happens to vitamin B12 from the time you take in food. So this is vitamin B12 in the food. Now that vitamin B12 binds to what we call arrow binder. So in the stomach, the vitamin B12 binds to what we call the arrow binder. Once you've taken the food through your mouth, arrow binder binds to vitamin B12. So we have B12 arrow binder complex, which is a combination of the vitamin B12 and the arrow binder. And then in the duodenum, what happens is that intrinsic factor, which we said is produced by the gastric mucosa, comes to bind with the B12 complex. So what happens is that intrinsic factor binds to B12 and thereby freeing the arrow binder. So what happens is that here we had B12 arrow binder complex, and then intrinsic factor competitively binds to vitamin B12, thereby knocking out arrow binder. So what we have is intrinsic factor B12 complex plus arrow binder, which is free. So the arrow binder is no longer bound to the vitamin B12. But what we have now is intrinsic factor bound to vitamin B12, and this happens in the duodenum. But then in the epithelial cells of the terminal ileum, where absorption takes place, what happens is that this intrinsic factor vitamin B12 complex binds to a receptor on the epithelial cells of the terminal ileum. So we have a receptor with intrinsic factor B12 complex bound together. And then we have three transporters here. Okay, we have three transporters. They are TC2, actually TC1, TC2, and TC3. But the one we need here for this absorption is the TC2. The one we need for absorption in the intestine is TC2, but we have three transporters of vitamin B12, So they are TC1, TC2, TC3. But in the intestine, the terminal ileum, we only need the TC2. So what happens? This receptor intrinsic factor B12 complex will be degraded. So what will happen? The intrinsic factor, watch this intrinsic factor will be degraded, and then the receptor also leaves the complex and goes back to position. So you see this arrow coming back here. This is intrinsic receptor coming back here. Then what is left is now B12 and TC2 transporter. Only B12 and TC2 transporter that leaves the terminal ileum into the circulation. So what does that mean? It means that intrinsic factor will not be absorbed alongside, will not be sent into the blood because it is degraded. It undergoes degradation while the receptor goes back to its position, and then the vitamin B12 is transported by transcobalamin 2 into the circulation. So which circulation do you think this would be? The blood is leaving, or this receptor B12 and the transporter is leaving epithelial cells of terminal ileum. Which blood vessel carries blood from the intestine, from this intestine? So remember we talked about the portal vein, yes? That takes blood from, different parts of the portal circulation and take the blood to the liver. So what happens is that this vitamin B12 now enters the circulation, and from this circulation it will be carried to the liver, the bone marrow, and everywhere else where it is needed. But remember, we're talking about erythropoiesis, and erythropoiesis takes place where? In the bone marrow and in the liver majorly. Okay, so it means that the vitamin B12 will be carried to the liver and to the bone marrow where erythropoiesis takes place. So transport of vitamin B12. Now, following absorption by the ileal mucosa cells, vitamin B12 is carried in the plasma by various transporting proteins. So there are 3 transport proteins, like I said earlier: transcobalamin 1, transcobalamin 2, and transcobalamin 3. But we are interested in transcobalamin 2 that carries from the intestine to the general circulation. So transcobalamin 1 is an alpha globulin produced by granulocytes. It functions as a circulating reserve store of B12. TC1 carries mostly methylcobalamin. We said we have different types of the cobalamin here. So methylcobalamin is transported by TC1. Then we have transcobalamin 2, is a beta globulin that is formed in the liver, and it is a dominant carrier of vitamin B12 immediately after absorption. It is the main agent for rapid transport of vitamin B12 to the body cell. So the main transporter of vitamin B12 is transcobalamin 2. And then we have transcobalamin 3, is an alpha globulin. TC3 may act as a defense mechanism by depriving pathogens of B12 at sites of infection. So some pathogens might want to use our vitamin B12 to for their pathogenesis, but transcobalamin 3 prevents that. So it kind of defends or prevents infections or pathogens from having access to our vitamin B12. So our emphasis majorly is on TC2, which carries the bulk of the vitamin B12. Now, this vitamin B12, where is it being carried to? So total amount of vitamin B12, so we're looking at the storage. Vitamin B12 will be stored in the body. Total amount of vitamin B12 in the body is 2 to 5 micrograms, adequate for 3 years. Major sites of storage of vitamin B12 is the liver. So that was why I told you that circulation, the blood is going to the liver, right, through the portal vein. And then it is excreted through the bile and shedding of intestinal epithelial cells. So some amount of vitamin B12 is excreted through bile. And then most of the excreted vitamin B12 is again absorbed in the intestine in what we call the enterohepatic circulation, the circulation between the intestine or the digestive system and the liver. Okay, so now what is the function of this vitamin B12? Why are we transporting the vitamin B12 to the liver and to other sites? Now, vitamin B12 plays a biochemical role in the synthesis of methionine, from homocysteine. Now, remember this is a little bit of biochemistry. So vitamin B12 biochemically help to produce methionine, and methionine is produced from homocysteine. So one of the things you would notice in the absence of vitamin B12, or maybe in a patient that has vitamin B12 anemia, meaning that there's lack of vitamin B12, is that there will be lack of methionine, but there will be excess homocysteine, because homocysteine is supposed to be converted to methionine in the presence of vitamin B12. But now, when there is vitamin B12 deficiency, there will be hyperhomocysteine or excess homocysteine in the blood, while there will be decreased methionine. Now, another function of vitamin B12 is that it helps in the conversion of methyl malonyl-CoA to succinyl-CoA. So anytime you lack vitamin B12, what will happen is that we will have excess methyl malonyl-CoA because it cannot be converted to succinyl-CoA when there is no vitamin B12. So just remember this.
What is that?
Methyl malonyl, succinyl-CoA. So these ones, they help in, the Krebs cycle. Oh, okay, you've not done biochemistry. So in the Krebs, in biochemistry, you will be taught what we call glycolysis. Okay, you'll be taught glycolysis, you'll be taught the Krebs cycle, and then what we call the electron transport chain. 3 main processes of glucose metabolism to produce energy. So succinyl-CoA plays a role. It's one of the metabolites involved in that circle. So glycolysis, you are breaking down glucose, and the goal, the end product you want to get is what we call ATP, energy, yeah, adenosine triphosphate. So succinate CoA plays a role in that circle, but you will do that later in biochemistry. Okay. Then, okay, let's go ahead. So look at this. Then, this is the role of vitamin B12 and folate in DNA synthesis. Now, we talked about methionine before, right? We said homocysteine is converted to methionine in the presence of vitamin B12, which is methylcobalamin. So without vitamin B12, homocysteine cannot be converted to methionine. So, but what happens? In this circle, you would see that this is folate. Let's take folate. So this picture is showing not only the role of vitamin B12, but also the role of folic acid. So here, this is folate, dietary folate, folic acid in the food that you take in, is absorbed in the intestinal cell, and then it produces methyl FH4. Now, this methyl FH4 is converted to FH4. Why? Because this methyl group is needed here. So this methyl group is given off, and then what we'll have will be FH4. Now, this FH4 also can be converted again to methylene FH4. But this process of conversion of methylene FH4 to FH2 is leads to the production of what we call thymidylate synthase. So for you to produce thymidylate synthase, you need folate. Folate will give you methyl FH4. Methyl FH4 can be converted to just FH4. Now, when you convert methyl FH4 to FH4, the methyl group comes here to form methylcobalamin, and that methyl group gives you methionine. Then this FH4 is converted again to methyl FH4, methylene FH4. Now, the conversion of methylene FH4 to FH2 leads to the production of thymidylate synthase. Now, this thymidylate synthase now leads to the production of what we call thymidine monophosphate. Thymidine monophosphate. Now, this thymidine monophosphate is used in DNA synthesis. Thymidine monophosphate is a type of pyrimidine. In biochemistry, you will be taught purines and pyrimidine. So this thymidine monophosphate is used to synthesize DNA. So what does this mean? It means that in the absence of vitamin B12, there will be no methionine, and methionine gives its methyl group. You see this met here, gives its methyl group, and that methyl group aid in this whole process, which leads to formation of thymidine monophosphate. Now, this thymidine monophosphate now helps in DNA synthesis. And without DNA synthesis, there could be no formation of new cells, new characteristics. Nothing can be formed. Proteins and everything cannot be formed without DNA synthesis. So this picture is simply showing you that vitamin B12 and folate play a role in DNA synthesis. So the essence of this whole circle here, the essence of this whole circle is the production of DNA. And that is why we said when we started talking about megaloblastic anemia, we said megaloblastic anemia is characterized by a defective DNA synthesis, a defective DNA synthesis. And the reason for the defective DNA synthesis is a lack of vitamin B12 and folic acid. So, and that will give us B12 deficiency anemia and folic acid deficiency anemia. Now, what do you need to know? Here you have what we call uridine monophosphate. Uridine monophosphate is converted to thymidine monophosphate in the presence of thymidylate synthase. So this is the enzyme that catalyzes the conversion of uridine monophosphate to thymidine monophosphate. But our goal is not all of these. Our goal is to produce DNA. Once we can get thymidine monophosphate, then we can synthesize DNA. But without folate, because this folate is this is 4-hydrofolic acid. So this FH4 tetrahydrofolate is gotten from this folic acid that you take in. And without this, you cannot produce this. And without this, you cannot produce this. And without this process, you cannot produce thymidine monophosphate. And without thymidine monophosphate, you cannot produce DNA synthesis. Again, without vitamin B12, homocysteine cannot be converted to methionine. Okay, let's see. So, general morphological features of megaloblastic anemia. So, we have talked about a little bit of biochemistry and the structure of the vitamin B12. But what is the general morphological features of megaloblastic anemia? So, the first thing you need to know in peripheral blood finding of a patient with megaloblastic anemia is that the hemoglobin is decreased. The hematocrit, why? Because we said in anemia is a decrease, yes, in hemoglobin or a decrease in red blood cell counts, all right? So hemoglobin could be decreased in megaloblastic anemia. Hematocrit could be decreased in megaloblastic anemia. Red blood cell counts could be decreased or it could be normal. Now, even if it is normal, those red blood cells are abnormal red blood cells because their DNA was not properly synthesized because of the lack of vitamin B12. So even though we have a normal amount of red blood cell, but the red blood cells are defective in their nature. And because all the function of all cells is determined by the DNA of the cell. So it means that without a proper DNA synthesis, you might have normal amount of red blood cell, but these red blood cells cannot function. Why? Because they were not properly produced. Their DNA, there was a defective DNA synthesis. So they cannot perform their normal function, even though the amount of the amount is normal, okay? Now, mean corpuscular volume is greater than 100 femtoliters in megaloblastic anemia. So mean corpuscular volume is greater. Remember that we said that the size of the red blood cells will increase, okay? So that might make the mean corpuscular volume look bigger than the normal amount, which is supposed to be 82 to 98 femtoliters. Mean corpuscular hemoglobin is increased also. Mean corpuscular hemoglobin concentration is normal. So the hemoglobin concentration is normal because we have normal amount of iron. We have normal amount of iron and we have normal amounts of hemoglobin, but the problem is not with hemoglobin really. The problem is with vitamin B12, not with hemoglobin. So mean corpuscular hemoglobin concentration can be normal, but what will happen is that those red blood cells will not be able to carry out their normal function since their DNA is not properly synthesized. Now, sometimes there will be a decrease in reticulocytes. So we have reticulocytopenia. There will be a decrease in amount of reticulocytes, and then total white blood cell counts can be normal or low. Why? Because we have two lineage. Okay, we have two lineage. We have the myeloid lineage, okay, and the lymphoid lineage during erythropoiesis or during hemopoiesis. Now, in the myeloid lineage, it produces red blood cells and neutrophil, basophil, and eosinophil, while the lymphoid lineage produces lymphocytes. So if we have a problem with myeloid lineage, our total white blood cell count might be normal or it might be low. Then our platelet count might also be normal or low. Then in severe megaloblastic anemia, you will have pancytopenia, in which all red blood cell lines would be low. So you will have erythropenia or anemia, as we said. You have leukopenia and you have thrombocytopenia, but only in rare or in severe cases of megaloblastic anemia. Now, in the peripheral smear, what will you see when you look at the red blood cells? The red blood cells will be macroovulocytes, so they'll be macrocytic in nature. They are macrocytic in nature, but they are normochromic. Why are they normochromic? Because we don't have excess hemoglobin, okay? Because we said that it is the iron in hemoglobin, or the heme, that gives the color to the blood. So it will be normochromic because we are not having deficiency of iron. So we have normochromic cells, but these cells will be bigger in size, macrocytosis, and their macrocytosis is the earliest sign in vitamin B12 deficiency. So if you don't know anything about vitamin B12 deficiency, you must know that there is macrocytosis. The cells are usually bigger than they should be because there is defective DNA synthesis. And when there is defective DNA synthesis, cell division is affected. And we said before that the more cells divide, the smaller they become. But now they cannot divide further as a result of defective DNA synthesis. So they look bigger in size. Then in severe anemia, in severe megaloblastic anemia, apart from the macrocytosis, you also see some abnormal cells. So we'll call that phenomenon anisopoikilocytosis. So you see cells having different shapes. They are not biconcave disc shape. They are not oval in shape. So they have some kind of abnormal shape. So we call that anisopoikilocytosis. And then we'll have basophilic stippling. So you'll notice that some of your white blood cells will look a little bit in the blood smear, they will look bluish or purple in color. So we'll call that basophilic stippling. Then you have some bodies we'll call Hohe-Jolly bodies in the blood smear, attached to the blood smear, and Cabot rings. So these are abnormal bodies that you find in the blood smear that are not supposed to be there. But because there is defective DNA synthesis, you find what we call Hohe-Jolly bodies, Cabot rings, and you see basophilic stippling. I will show you the blood smear very soon, and you will see the color and the different shapes of the blood cells. So remember that in MCQ exam, they can ask you, which of the following cells would be found in megaloblastic anemia? So remember, you'll find Hohe-Jolly bodies and Cabot rings, and then you'll find macrocytosis. And then your neutrophils, you'll see that they are stained purple. Your white blood cells will be stained purple, or I should say your granulocyte, yes. Your granulocyte will become purplish in color, having more lobules. I'll show you later. Now, late or intermediate erythroblasts with fine open nuclear chromatin, so I called megaloblasts, may be seen in the peripheral blood in severe anemia. So you can find megaloblasts in severe anemia. Okay, so now if you look at these, you can see these cells, right? You can see this blood smear. We said that the normal shape of the red blood cells are supposed to be biconcave disc shape. But these cells here are looking oval in shape. They're looking oval. So we have ovalocytosis. And the cells are looking bigger than the normal red blood cells. So they are, we call macro ovalocytosis. So they are looking bigger than they should be. in this diagram, the mean corpuscular volume is 134 femtoliters, so greater than 100. Okay, and again, you see this purple color here. I think maybe there's a better slide that will show you some granulocytes having more than 5 lobules, When we were doing granulocytes, we did eosinophil, neutrophil, and basophil. We said that the highest number of lobules that the granulocytes have is 3 to 4. But in this megaloblastic anemia, you will find that some granulocytes have more than 5 lobules. So it is a sign that there is megaloblastic anemia. So these are the cells that are looking bigger in size with this basophilic stippling. That's why this color is looking like this. Okay. So peripheral smear, we said the white blood cells, they could be normal count or reduced. We already talked about this before. Platelets could be normal or decreased. And then giant platelet cells can occur. So you can find some platelets that are bigger than the normal size. Okay, so look at what I was talking about. Look at this. This is the granulocyte here. You see the granulocyte? How many lobules can you see here?
5.
5. But normally it shouldn't be more than 3 or 4 in granulocyte. But in vitamin B12 deficiency, you will see purple stippling or basophilic stippling with granulocyte having up to 5 lobules. So that is a sign. Whenever you see a blood smear like this, just know that this is megaloblastic anemia. And the cells are looking oval and bigger in size. So that is a blood smear for megaloblastic anemia. Again, you will see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Almost this one has almost 11 lobules. Okay, so this is a sign that there is megaloblastic anemia. Okay, so you remember in the bone marrow where we said that the erythropoiesis takes place. So what happens is that the bone marrow becomes hypercellular. The myeloid lineage will have erythroid ratio decreases or reversed. Under normal circumstances, there are 3 myeloid precursors for each erythroid precursor. 3 myeloid precursors for 3 erythroid precursor, resulting in 3-to-1 ratio. Okay, but what happens in megaloblastic anemia? There's a decrease in this myeloid to erythroid ratio. So instead of having 3 myeloid to 1 erythroid, we might have 1 myeloid to 3 erythroid, or we might have 3 myeloid to 2 erythroid. So there's a decrease in the ratio, myeloid to erythroid ratio. Instead of 3:1, we might have 3:2, or we might even have 2:1 or 2:3. Then in erythropoiesis, what happens at the end will produce megaloblastic cells. Okay, so megaloblasts, how do they look? The cell and the nucleus size and amount of cytoplasm are increased. So a megaloblast has increased nucleus size and increased cell size. Nuclear chromatin is sieve-like or stippled. It is open. Then nuclear cytoplasmic dissociation. So the nucleus and the cytoplasm are supposed to be in a certain ratio. But now, because the cells are bigger and the nucleus size is bigger, there is dissociation between the what you call nuclear cytoplasmic ratio. So it is not synchronic. Then you have abnormal large precursor cells, which are promegaloblasts, and early megaloblasts are increased. And then we'll have, okay, now that is because, the reason that is happening is because there is much arrest of maturation. The cells cannot mature because there is absence of DNA synthesis. And when the cells cannot mature, they cannot give rise to a normal red blood cell, a mature red blood cell. So what we'll have will be a megaloblast. And I would say abnormal mitosis will increase because of lack of DNA lack of DNA synthesis. Okay, so granulocytes also display megaloblastic changes. So your neutrophil, eosinophil, and basophil would display megaloblastic changes also. So you can find what we call giant metamyelocytes with horseshoe-shaped nuclei. And like we said before, some of them will have more than 5 lobules. Then for your platelets, megakaryocytes are often large. So your platelets could be large also with multiple nuclear lobes. Okay, so this is not, for me, this is not important. Biochemical finding. So in megaloblastic anemia, there could be increase in serum unconjugated bilirubin. And the reason for this serum unconjugated bilirubin is because of ineffective erythropoiesis. Now, when you produce abnormal cells, your body does not recognize these abnormal cells, so they will be destroyed. And once you destroy these red blood cells, abnormal red blood cells, we said the hemoglobin in the blood cells, in the blood cells will be converted to bilirubin and ferritin. So in megaloblastic anemia, because there is destruction of the abnormal red blood cells, the amount of bilirubin, unconjugated bilirubin in the blood will increase. Okay, and then we have increased lactose dehydrogenase, and then we have normal serum iron and ferritin. So remember that in megaloblastic anemia, we don't have any problem with iron. So you will have normal serum iron and normal ferritin. But in iron deficiency anemia, it will have decreased serum iron and decreased ferritin. But in megaloblastic anemia, that is not. Now, what are the causes of vitamin B12 deficiency? Why do people have vitamin B12 deficiency? The first reason is insufficient dietary intake. So a lot of people are not taking in enough vitamin B12. But this is rare because only people, we already said that your liver, dairy products, meat, fish contain vitamin B12, right? So anybody who eats meat and eats fish and eats dairy products should have enough vitamin B12. And only small amount of vitamin B12 is needed daily. So it is rare for somebody to have vitamin B12 deficiency. But because we have people who are strict vegetarians, as I said at the beginning of the lecture, these vegetarians, they don't eat meat at all. They don't eat fish. They only eat vegetables and fruits. So as a result, they would have insufficient dietary intake of vitamin B12, and they are prone to having vitamin B12 or megaloblastic anemia. Then sometimes there is deficient absorption of vitamin B12. So these people, they eat normal amount of vitamin B12, but the B12 cannot be absorbed. Now, why can't the vitamin B12 be absorbed? Remember that I told you that for you to absorb vitamin B12, you need one protein that is called castofactor or intrinsic factor, right? So that intrinsic factor, we said it is produced in the parietal cells of the stomach. So what happens is this. When there is pernicious anemia, now listen to this, in pernicious anemia, there is autoimmune destruction of the parietal cells of the stomach. And once there is autoimmune destruction, antibodies go to destroy the parietal cells. The parietal cells can no longer produce intrinsic factor. And when there is no intrinsic factor, there will be no absorption of vitamin B12 because we said vitamin B12 is only absorbed in the presence of intrinsic factor. So in pernicious anemia, there is autoimmune destruction of the parietal cells so that they cannot produce intrinsic factor, or there is autoimmune destruction of the intrinsic factor itself. So the parietal cells could produce intrinsic factor, but antibodies destroy the intrinsic factor so that they cannot function. They cannot bind to vitamin B12 and help vitamin B12 to be absorbed. So we call that pernicious anemia. So pernicious anemia is autoimmune condition in which intrinsic factor or perital cells are destroyed by antibodies. And as a result, vitamin B12 cannot be absorbed. Do you understand that?
Yes, sir.
Good. Now, another reason for deficient absorption of vitamin B12 is what we call total or partial gastrectomy. So in gastrectomy, there is a kind of recession of the stomach or excision or surgical removal of parts of the stomach. And when you cut away the parietal part of the stomach, for example, whether it is partial gastrectomy or total gastrectomy, it could affect the parietal cells. An absence of parietal cells means absence of intrinsic factor. An absence of intrinsic factor means inability of vitamin B12 to be absorbed. Okay, good. Then sometimes prolonged use of proton pump inhibitors or H2 receptor blockers. So patients who are taking proton pump inhibitor or H2 receptor blockers are patients that have gastric ulcer. So they have ulcer or they have peptic ulcer. Now, these patients take what we call proton pump inhibitor to inhibit the release of hydrochloric acid, because proton pump releases hydrogen ions and hydrochloric acid is formed also in the process when the hydrogen binds to chlorine. And then we also have H2 receptor blockers, which are a kind of histamine receptor blockers. Now, when you take these drugs for a long time, they prevent the absorption of vitamin B12. So proton pump inhibitors and H2 receptor blockers can decrease the ability of vitamin B12 to be absorbed. So remember that. So pernicious anemia, total or partial gastrectomy, and prolonged use of PPI or H2 blockers in patients with peptic ulcer disease, there will be deficient vitamin B12 absorption. Then sometimes there could be a disease of the small intestine that causes malabsorption, so malabsorption syndrome, or maybe irritable bowel syndrome, and vitamin B12 cannot be absorbed. So that will also lead to deficient absorption and lead to B12 deficiency. Then we have fish tapeworm infestation. So this is the parasitic infection by Diphyllobothrum latum. Diphyllobothrum latum. If you did biology, I think you would have heard of Diphyllobothrum latum. Now, that parasite also decreases when somebody is infected with this virus. It destroys the intestinal mucosa and makes it difficult for absorption of vitamin B12. So all of these, one, insufficient dietary intake or deficient absorption, any of these would cause deficient absorption, will lead to vitamin B12 deficiency. And when there's no B12 deficiency, there is no proper DNA synthesis. And when there's no proper DNA synthesis, we produce megaloblast. Okay. Pernicious anemia. So here is just a little explanation of what pernicious anemia is. But we said pernicious anemia causes intrinsic factor to be destroyed. So what happens in pernicious anemia? Now, pernicious anemia is a disease of elderly people, okay, around the age of 60 years. There is a tendency to form antibodies against multiple self-antigens. So antibodies are formed against the parietal cells or against intrinsic factor. And so they will prevent absorption of vitamin B12. So immunologically, autoimmune destruction of gastric mucosa happens. There is chronic atrophic gastritis, which leads to loss of parietal cells. Why is there chronic atrophic gastritis? Because antibodies are destroying the gastric mucosa. And as a result, parietal cells number will decrease. And when there's no parietal cells, there cannot be production of intrinsic factor. Now, 3 types of antibodies. So we have type 1 antibody, about 75%, blocks vitamin B12 and intrinsic factor binding. So remember we said that vitamin B12 must bind to intrinsic factor, right? We talked about that in this scheme I showed you earlier. So if we have antibodies that prevent B12 from binding to intrinsic factor, it means that B12 cannot be absorbed. Then type 2 antibody prevents binding of intrinsic factor B12 complex with ileal receptors. Remember the receptors I told you about, that intrinsic factor and B12 complex will bind to receptors in the ileum. So antibodies can prevent this binding to happen. And then in type 3 antibody, what happens is that the antibodies are against specific structures in the parietal cells. So three things the antibodies can do. They can destroy parietal cells, or they prevent the binding of intrinsic factor vitamin B12 complex to receptors in the ileum, or they can prevent the binding of vitamin B12 and intrinsic factor. And any of these will lead to inability to absorb vitamin D and once vitamin B12. And when you cannot absorb vitamin B12, what happens is that you end up getting megaloblastic anemia. Megaloblastic anemia. So here is just a repetition of what we already said. So associated with other autoimmune disorder. So people with pernicious anemia, right? People with pernicious anemia would also have Hashimoto's thyroiditis, Graves' disease, vitiligo, diabetic mellitus, primary hyperparathyroidism, Addison's, and myasthenia gravis. So all of these are autoimmune disorders. So if that patient has antibodies destroying his parietal cells, it means that there is also a possibility that that patient is also having antibodies destroying the thyroid gland also, or destroying the islet of Langerhans, leading to diabetic mellitus or the parathyroid gland. So anybody with pernicious anemia could also have Hashimoto thyroiditis, Graves' disease, vitiligo, diabetes mellitus, primary hyperparathyroidism, Addison's, and myasthenia gravis. So remember, well, you will do this later in higher classes, okay? But for now, just know that pernicious anemia would cause megaloblastic anemia because of destruction of intrinsic factor and parietal cells by antibodies, okay? Now, patients with pernicious anemia have increased risk of gastric cancer. Patients with pernicious anemia having increased risk of gastric. Okay, so diagnostic features: moderate to severe megaloblastic anemia, leukopenia with hyper-segmented neutrophils. So this is what I was telling you. The neutrophils will be hyper-segmented, so they have up to more than 5 lobules, okay, more than 5 lobules. Then there could be mild to moderate thrombocytopenia, decrease in thrombocytes. You could have mild jaundice due to ineffective erythropoiesis and peripheral hemolysis. So when there is ineffective erythropoiesis, the red blood cells that are formed, they are abnormal red blood cells. Your body does not recognize them, and so your body destroys them. So, and this hemolysis will lead to excess bilirubin, which is what we call jaundice. Okay. Then there will be neurological changes. Why? Because methionine, right, which we said when you convert homocysteine to methionine, methionine plays a role in neurons or nerve cell. So it means that in vitamin B12 deficiency, there will be some neurological changes because the neurons would be lacking methionine, which they need for their function. Then we will have low level of serum vitamin B12. So vitamin B12 in the blood, the level will decrease. And then you will have elevated levels of homocysteine. Why? Because we said in vitamin B12 deficiency, homocysteine cannot be converted to methionine because homocysteine needs vitamin B12 before it can be converted to methionine, right? Good. So because you cannot convert homocysteine to methionine, you will have excess or elevated homocysteine level. Then you could have number 8, striking reticulocytosis after parenteral administration of vitamin B12. in patients with vitamin B12, when you give them vitamin B12, right? You give them vitamin B12 IV, what will happen is that there will be increase in reticulocytes. Why? Because that vitamin B12 you are giving them will go to increase erythropoiesis. Before they lack vitamin B12, right? But now you have given them vitamin B12, so there will be increased erythropoiesis, excess production. And whenever there is increased erythropoiesis, there will be increased reticulocytes. Okay, so you have reticulocytosis. Then serum antibodies to intrinsic factor and anti-parietal cell antibodies in serum. So another way you can diagnose megaloblastic anemia is that you will see antibodies to intrinsic factor and you will see anti-parietal cell antibodies, because we said that antibodies will destroy intrinsic factor and destroy parietal cell. So that could be a sign that the person has megaloblastic.
That's what I
Sorry?
Sorry, sir.
Okay. Then you do abnormal Shilling tests, pentagastrin fast achloridria. So these are just laboratory tests you do to confirm that this patient has megaloblastic anemia. So to confirm that the patient has megaloblastic anemia, you do Shilling test and pentagastrin fast achloridria. So these are laboratory tests. Now, what will you find also? We said that one of the cause of vitamin B12 deficiency is gastrectomy, when there's a surgery, of the stomach. So in total gastrectomy, you have removed the parietal cells, and once you remove the parietal cells, there will be no intrinsic factor, and when there's no intrinsic factor, you cannot absorb vitamin B12. Then in partial gastrectomy, maybe only some parts of the parietal cell is removed. So you might still have some small amount of parietal cells, but they are not enough for the absorption of vitamin B12. Okay, so I think we will stop here. All these are just explaining the reasons why vitamin B12 cannot be absorbed. So we said that in some malabsorption diseases, right, B12 will not be absorbed. So that's just what this slide is showing. So I don't think we need to do this. The infestation of fish by tapeworm, Diphyllobothrium latum, I mentioned it before, will lead to vitamin B12 deficiency also. Okay, the last thing you need to know. So what are the signs and symptoms of a patient with vitamin B12 anemia? So the person will have anemia, mild jaundice, and sometimes neurological involvement because of absence of methionine. Now, neurological involvement in the form of peripheral neuropathy, subacute combined degeneration of spinal cord, and cerebral changes. So the person might have personality changes, dementia, and psychosis. So anytime they give you a question and they say that the patient has megaloblastic anemia with macrocytes, but the patient is having some neurological problems, know that it is megaloblastic anemia. So how do you know megaloblastic anemia? One, you will see that there are macrocytes in the blood smear. There is increased increased size of the cells, so that's macrocytes. There is increased segmentation of the neutrophils with more than 5 lobules. And then the patient is having a problem with, maybe the person has pernicious anemia, or the person has one malabsorption problem. So you know that vitamin B12 is not being absorbed. Plus, the person will have some neurological disorders. So that is to tell you that the patient is having vitamin B12 anemia. So patients can present with only neurological abnormalities without megaloblastic anemia in vitamin B12 deficiency. So this is just how you do laboratory features. So morphological changes of megaloblastic anemia in peripheral smear of the blood. Then serum vitamin B12 assay. So you'll see that there's a decrease in vitamin B12. Then methylmalonic acid and homocysteine in serum, you see that there will be increase in homocysteine and methylmalonic acid, while there will be a decrease in methionine. Then you do the Shilling tests, and then you will find intrinsic factor to antibodies in the serum. So your homework, I'm going to give you homework. Your homework would be go and read about Shilling tests, how it is done, and how you can use it to confirm, because it is the confirmatory test for vitamin B12 deficiency. So I'm going to ask you in the next lecture to tell me about the Shilling test, what is done in the Shilling test. Okay? Yeah, good. So I think that would be all for vitamin B12 deficiency anemia. Do you have any question?
No, sir.
Okay, it's a lot of material today. Yeah, a lot of information.
Yeah, I wanted to ask you about the video.
Yeah, I'm going to put the video on YouTube so you can watch it there.
Okay.
Okay, take care. See you. Bye bye.